preparing. Yeah, we are live right now.
All right.
Hello, good evening, Dr. Lou, Dr. Alexander Brescia, Dr. Clauden Louis. It's a pleasure to have you all here. So feel free to present yourself, and we would like to start with Dr. Clauden Louis. It's a pleasure to have you all here. Thank you very much.
Perfect. Thank you so much, Rodolfo, for the invitation to present today. And we really enjoy this collaboration between your organization as well as our organization in the US here. So I'm Xiao Xiao, and I'm currently an integrated cardiothoracic surgery resident. We'll get more into that about the specific programs in the US for training. Currently at Emory University in Atlanta, Georgia, and then also this year's president of the Thoracic Surgery Residents Association. And with me today, we have Clauden Louis and then Alex Brescia as well. So I'll have them do their own introductions real quick here before we get started.
Sure. So I'm Alex Brescia. I'm at the University of Michigan, also in an integrated program like Xiao Xiao. At Michigan, we do 6 clinical years and 2 research years in the middle. So I'm in my 5th year overall, finishing the 2nd year of research. I'll have 3 clinical years left after that.
All right, I'm Clauden Louis. I am a year 4 resident, also integrated at University of Rochester, which is in New York State. We have 6 clinical years in total. I am now finishing currently year 4 of 6.
Rodolfo, so I think you wanted us to talk a little bit about the different pathways and curriculum of training of cardiothoracic surgery residents in the United States, and then also specifically about our Thoracic Surgery Residents Association and our projects and resources. So that's kind of the format we'll follow here. That's good with you. So I'll get started first here. So this presentation is going to cover the basics of how training works in the United States. I'll talk about our different training pathways, and then a basic overview of how our curriculum is structured, although notably there is no standardized curriculum currently in the US either. So starting with pathways. So the beginning of cardiothoracic surgery in the United States, initially it was created around the late 1920s when the field consisted of mostly treating empyemas and tuberculosis. And there's been significant adaptations and evolution over the last century, as I'm sure it has been in Brazil and as well. And training programs have needed to continually to evolve to change in practice. So in the US, there are 2 major governing societies of training programs. It's the American Board of Thoracic Surgery, the ABTS, and the Accreditation Council for Graduate Medical Education, or the ACGME. And they're primarily the ones responsible for regulating the number of programs and the training positions in the US. Board certification for cardiothoracic surgery requires passing a computer-based multiple choice exam and an oral examination at the completion of training. And board certified cardiothoracic surgeons are eligible to practice in both cardiac and general thoracic surgery in the US. So the evolution of cardiothoracic surgery has undergone quite a significant change, and particularly in the last 2 decades as well. In the mid-late 2000s or so, cardiothoracic surgery training in the US actually reached a low point where there were more unmatched positions than matched positions. There was declining surgical volume. There was a lot of uncertainty about where the future was headed, particularly in light of new advances in interventional cardiology as well. So there needed to be significant reform at this time if the specialty was to remain relevant and successful. And you can see here, this is the matched program data from the 1990s over all the way to about 2008 is what we have data for right now. So a changing paradigm was needed. In 2003, the American Association for Thoracic Surgery, or the AATS, president at the time, Dr. Crawford, called for a change in the training paradigm to rejuvenate the specialty. And he specifically said that there must be efforts to engage medical students and residents, change training programs, and adapt to changing perceptions. And this would require innovation in simulation-based training, new models of resident training, and a more streamlined educational curriculum. And this was, at the time, the current medical training in the United States. I want to go over this before talking about the different training pathways for cardiothoracic surgery. So we do 4 years of college here, then 4 years of medical school, and then we match into a residency program. And there are a few different residency pathways to get into cardiothoracic surgery. The ABTS currently recognizes 3 particular pathways that lead to board certification in cardiothoracic surgery. There's a traditional pathway, which involves 5 years of general surgery, and then a 2 to 3 year fellowship in cardiothoracic surgery training. In addition, there's a fast track 4+3 program that's 4 years of general surgery, 3 years of fellowship. And then the pathway that actually Claude and Alex and I, all 3 of us, are in is this integrated 6-year combined program. And this is a relatively new development, and it really emerged in the 2000s and afterwards, when you saw previously on that chart where the low point in cardiothoracic trainees and interest in cardiothoracic training was at a decline at that point. So the application process, the curriculum, and of all these pathways vary quite differently, and even vary between institutions that offer these tracks as well. So in this traditional track pathway, medical students apply to complete general surgery residency, which is 5 years, with the option to conduct 2 additional years of research. During their 4th year of general surgery, residents apply to and then try to match into a cardiothoracic fellowship program. And there are both 2 and 3 year track fellowship programs, depending on the particular program or institution in the US. And then ultimately they get board certified by both the ABTS and the American Board of Thoracic Surgery or they're eligible for the American Board of Surgery and the American Board of Thoracic Surgery, so they can practice general surgery technically as well as cardiothoracic surgery. And then in addition, they have super fellowship training is an option if additional training in heart failure, transplant, aortic surgery, congenital is warranted. In this other pathway called the Fast Track 4+3 program, medical students also apply directly into a general surgery program. And then in their 2nd year of general surgery, they apply for a cardiothoracic track within the same institution. Some of them will also do some years of research in between this. And then ultimately they go on to complete cardiothoracic surgery training, a 3-year process at their own institutions, and then ultimately get board certified by both the American Board of Surgery and the American Board of Thoracic Surgery. So these residents also, when they graduate, can practice both general surgery and cardiothoracic surgery, and then can also get additional super fellowship training in respective subspecialties. And then finally, this integrated program is a track where medical students apply directly out of medical school to this integrated track. We do also complete some general surgery rotations in the first 2 to 3 years of training. The last 3 years mirror the same traditional track. We have some programs allow for additional years of research. For instance, Alex and I have both taken some time to do some research at our institutions. And then at the end of training, we are board eligible for the American Board of Thoracic Surgery, but we will not be able to practice general surgery because of the integrated pathway. And then in addition, we can also do super fellowship training as well. So this is just, there's a lot of information that I just covered, as I know, but this is a little overview on each of the 3 pathways. The traditional track is considered the gold standard in some ways. It's the way that cardiothoracic surgeons have been trained for decades, but it is considered the longest pathway. In this Fast Track 4+3 program, resident performance can be assessed in general surgery training before they progress to a fellowship, and it does maintain the opportunity to have a chief residency year in general surgery. The integrated I-6 pathway is considered an accelerated pathway, and in some ways, over the last few years, at this point, we've had many residents who have graduated from this program and are now practicing surgeons all over the country, but in some regard, it is still new and considered experimental, and it leads to board certification only in cardiothoracic surgery and not in general surgery. So again, this is another summary slide of all of these. And Rodolfo, I can send you a copy of these slides if you're interested for anyone who would like a copy to see it in more detail. So that's a basic overview of the pathway to becoming a board certified cardiothoracic surgeon in the United States. And I'm going to briefly touch on the different curriculum of training currently. So first of all, I want to make clear that a standardized curriculum in training does not exist. There's just too much variability. Some institutions have some strengths in certain subspecialties and not in others. Different rotations are going to be different for each of those institutions. But the goal of each training curriculum and each training pathway is to prepare a resident to be able to operate independently and safely in cardiothoracic surgery. So many different components must be considered, including how a resident acquires technical skills, decision-making, judgment, clinical knowledge, research, leadership, team-based training. Different institutions, as I've said, have different strengths. And there's also increasing financial and regulatory board pressure for the best possible outcomes. And so that does make it difficult to prioritize training residents. And I think that is not a factor that's unique to the US. It's probably all over the world that's unfortunately a factor that needs to be considered. So curriculum here by the numbers. So currently eligibility for American Board of Thoracic Surgery certification is dependent on the completion of a certain amount of time spent in training and a performance of a minimum number of index cases as the primary operating surgeon. So generally accredited programs in the US are restricted to an 80-hour work week, which is averaged over 2 to 3 weeks. We generally take call every few days or so, approximately 2 weekends or so a month. The American Board of Thoracic Surgery requires an average of 125 major operations each year as the primary operating surgeon, with a minimum of 100 in any one given year. Residents who trained or started training after 2007 must actually meet specific operating requirements for one of two pathways, either cardiac or general thoracic. So here is maybe a little bit small for people to see, but this is a general list of case requirements to be board eligible for cardiothoracic training in the US. And you can see that the requirements in each of these categories, whether it's congenital, adult cardiac, lung, esophagus, VATS training, are going to be different whether you're on a cardiothoracic pathway, a general thoracic pathway, which means you're going to primarily practice thoracic surgery versus cardiac surgery. And you have different variability in the caseload requirements. And there's a lot of variability in graduating residents based on whether they're cardiac track or thoracic track, as you can see in the number of cases that they perform in terms of CABGs or AVRs or other operations that are listed here. So in this paper that was written in 2013 that looked at different curriculum across different pathways of training. There's a lot of acronyms here, but there's comparing integrated programs versus 2 to 3 year traditional track programs versus 4+3 programs, all the pathways that I had mentioned earlier. There's a lot of variability in how much time the resident spends on a cardiac rotation, on a thoracic rotation, or a congenital rotation. I think just driving home the point that there is no standardized curriculum. We try to just ensure that the resident gets the number of cases that they need in order to meet board certification. So in this integrated 6-year program that the three of us are in, briefly, this is how it's broken down. The first 3 years are predominantly general surgery, and you get some early exposure to cardiothoracic surgery and some adjuncts to cardiothoracic surgery training, including experiences with imaging, perfusion, some additional exposure to time in the ICU as well. And then the last 3 years for us are generally similar to a traditional track program where we have rotations in cardiac surgery, thoracic surgery, and congenital surgery. And then we also have some time that's devoted to other emerging areas of training, which includes structural heart, TAVR, TEVAR, minimally invasive training, aortic transplant, robotics as well. So I'm going to specifically speak to I6 residents because that is, the pathway that we are most familiar with here. And there's a lot more data published right now on the I6 pathway. This is kind of a general pathway of operative experience for I6 residents based on their year. So if, in general, if they are thoracic, time spent in a thoracic OR for thoracic track residents are going to gradually increase here, and the time spent in general surgery will gradually decrease across training over the 6 years of training. And then this is a general breakdown. We training for when we train in CABG or AVR, the general process involves training based on components for technical skills acquisition. So this is a guideline of when this paper was published a few years ago, a PGY1. Most of the PGY1s were doing sternotomy. And by PGY 3 or 4 year, they were doing some IMA harvest. Some were doing some valve sutures and potentially starting to do some coronary work. And then moving on to later years, a reduced sternotomy, even in later years, was still relatively rare to do. So the goal now for training is, instead of just a time-based model, training is evolving to a more competency-based and based education. So the goal here is to allow each training institution more flexibility to design their program, but also ensure that core competencies are standardized and met. And this also gives some flexibility in the recognition that residents acquire different skills at different speeds. So this is something I think that we at Emory do, and I'm sure is similar at Michigan and Rochester as well. We have these competency-based models that we go through throughout training, and every couple months or so we sit down with our mentors and look at where we're at in terms of each of these boxes, going from level 1 all the way to level 5. So I just took, a sample of what this would look like for medical knowledge for ischemic heart disease. So level 1, which probably someone who's just starting residency, these are the things that they're expected to know. So some of the basic anatomy, some of the presentations of ischemic heart disease, diagnostic tools, all the way over to level 5, where they're understanding more of the outcomes of ischemic heart disease, understanding the syntax score, and then going through all of these check boxes as they go through training. And then the same goes for patient care and technical skills for ischemic heart disease. So from level 1, demonstrating some basic surgical skills, all the way to level 5, performing a reoperative CABG operation and independently performing some procedures as well. And then you're expected to slowly progress through these boxes as you go through training. And to optimize the training that we have in the operating room, simulation-based training is emerging as more and more important, as well as an adjunct to training, and something, actually during this time of coronavirus that we have tried to incorporate more in training as well. So these are these little heart vessel anastomosis boxes that are sponsored by the Thoracic Surgery Directors Association. Generally, every resident who is in a ACGME program gets one of these box trainers, and you can practice anastomoses using these plastic tubing models on your own time. And I wanted to go through that we have various, for this model in particular, we have grading schemes where you can also get better at using this particular simulator. For instance, this is a 13 component-based assessment tool, and I just did a snapshot of a few of these items. So you can be graded on graft orientation, on bite, on spacing, from a grade of 1 where you're not able to orient the graft, to a grade of 5 where you're able to orient it and there's no hesitation, you're able to do it very consistently. And we actually are also standardizing the faculty assessment of the trainees as well. And so this is a project that I worked on where we looked at all 13 components of using that anastomosis model and trying to get the faculty graders to also agree on where the resident was at each point in this component-based system. So as the curriculum has continued to evolve, endovascular therapies, robotic therapies are becoming more and more prevalent. We have, as the TSRA and our accreditation councils have also recognized the need to incorporate this into training. And currently, TAVR and all other endovascular techniques are also becoming incorporated into the standard for board eligibility and board certification. So in conclusion, there are 3 major pathways to becoming cardiothoracic surgery in the US, and we anticipate that all of them are still going to remain available and valid. There's benefits and drawbacks of each, and trainees and programs generally make their own decisions about what the best fit is for them. There remains great interest, and there's also some uncertainty regarding the optimal way to train a cardiothoracic surgeon. I don't think we know the best way. I think it's dependent on a lot of other aspects. And so I think these 3 pathways are still relevant and available because of those reasons. As a specialty, we're moving away from a time-based model, time spent on certain rotations, to more of a competency-based model. And I showed you some of those competency-based guidelines in this presentation here. And we're still continuing to adapt to the changing practice and innovation of current training. Okay, before I move on, any questions about just on pathways training from anyone listening?
Yeah, just let me find these questions.
Okay.
And they asked about the minimally invasive training program. If you guys learn the minimally invasive surgery at the residence or just after the residence, if you have.
Yeah, I'll comment briefly, and then Alex and Clauden, feel free to jump in here as well. At Emory, I think it's institution specific. Some institutions may have more experience with minimally invasive, and they may have a particular attending who specializes in minimally invasive, so you'll get more exposure to it. There's currently not really a standardized, it's not a standardized part of board certification for using minimally invasive surgery. So typically, if you want to have that be your primary practice, most people nowadays are getting additional subspecialty fellowship training in minimally invasive surgery. So I don't think that, at least at Emory, that is not, core rotation for us.
I guess I'll speak to my institution at the University of Rochester. We have the ability to practice with the attendings of our choosing. So it's like an apprenticeship model. We have one attending in particular who does all his cardiac surgery cases, minimally invasive. So if you're on his service, you're doing minimally invasive, and he tries to ingratiate you to be a part of the procedure. So you're able to get kind of those skills down, and either you'll be comfortable or you'll say, I need to see an additional fellowship. And some people are comfortable coming out of training with the cases that we're doing. In regards to thoracic surgery, I want to make sure that we specify that there is a difference, at least in the United States and in major academic institutions. Most of the procedures are minimally invasive. And I say that to say that I hardly ever do open procedures anymore. I know that sounds crazy to say, but when we do lobectomies, they're all minimally invasive, video-assisted thoracoscopic surgery. When we're manipulating the paraesophageal hiatal hernias, we're doing those minimally invasively and hardly ever doing anything open. So I would say it depends on what specialty you're referring to. Cardiac in particular, it's specialty and practice specific. And then for thoracic surgery in academic institutions, many are open. Many are minimally invasive as opposed to open.
Yeah, I would echo a lot of what they said. At University of Michigan, we do have some minimally invasive cardiac surgery, but we don't have like a rotation where that's what you do the whole time. So it's a little more along the lines of what Xiao said, where there's some exposure to it on an individual basis, but it's not a, and I think it's largely driven by the fact that it's not specifically required in order for us to be boarded. And so that kind of drives a lot of what residents will do and what the focus will be on. And it might be soon, but it's not currently. And I'm speaking just about cardiac surgery. And I kind of like it like that, to be honest, because it gives you the opportunity to do a lot of open cases, when you're learning to operate. And then from there, you can move to more minimally invasive. In terms of general thoracic, I would echo what Clauden said. The majority of those are minimally invasive for the lung and esophageal operations. I think a little bit different at Michigan than other places. We do also do a good portion of open cases still. We do transthoracic hiatal hernia repair through a thoracotomy, which I know are not done in a lot of places. And so I think from a training perspective, it's really good experience. The one thing that we don't do regularly is robotic cardiac, but we do robotic thoracic. And so we get a lot of experience using the robot, which I think can be translated into really either specialty down the line.
Thank you. The second question is for everybody. What are your thoughts about simulated breaths in cardiothoracic surgery? We know about it. Clauden Louis is really important. For what about you guys, Clauden and Alexander Brescia, about the simulated breaths in cardiothoracic surgery for the first years?
Yeah, so we actually last year we revamped our didactic curriculum, and so we have a weekly didactic every Thursday morning. And the way that we restructured it is that, and this is before COVID, so it's not really true anymore, but the way we structured it is we had a case, sort of a case review first, and so a resident would present a case, and then there's a faculty member who is paired with them, and it's kind of a test or oral board preparation style encounter. And we do that for about a half an hour, and then we had some sort of simulation after that for approximately an hour. And so that kind of ranged from a lot of things. We did a robotic simulator, we do bronchoscopy, we did an EGD, and then we would do wet labs with pig hearts, and we do aortic root operations. And so it kind of was the full spectrum of simulation. And in addition to that, on an individual basis, like Xiao mentioned, I think most thoracic, meaning cardiothoracic residents have that kit. And I think it's kind of variable by individual and variable by institution, how much of that you're doing, and also by level. If you're ideally, the more senior you are, if you're in the OR most of the day, then that is your simulation, because that's the real deal. But I think that it's an important adjunct to training, but definitely can't replace being in the OR.
I guess I can speak a little bit on simulation. My program director, Dr. George Hicks, he was one of the authors on one of the studies that Dr. Lou showed. He does a lot of simulation. He's one of the founders of our annual boot camp, where we do simulation all together in North Carolina. All of the residents from a particular year, usually PGY 3 and 4s of integrated, and usually first year fellows, get together and do simulated programming together, covering essentially all of the specialties. But I'll echo what Alex said. On Thursday mornings, we get together and we do some type of education, and usually twice a month, we do something that's physical and hands-on. So a pig lab, for instance, where we do an anastomosis and sort.
All right, thank you very much. And we'd like to continue, Dr.
Okay.
Shalom.
All right. Good. So I'm going to just very briefly go over the TSRA and what we do, and then Clauden's going to talk about our projects and resources in some more detail. Okay. So the Thoracic Surgery Residents Association, it's an organization of all the cardiothoracic surgery residents in North America, and all residents who match into an accredited training program in the US or Canada are automatically considered members of the TSRA. It was founded initially in 1997 and serves to represent the interests and needs of cardiothoracic residents across the country. The structure of this TSRA consists of an executive committee, and it serves as a primary leadership in the governing body for the TSRA. And all of our work is generally done by four main committees: the Projects Committee, Education Committee, Membership, and Communications Committee. And then we elect these positions at the start of the academic year, and the residents are free to join any of these committees as well. So a brief overview. So we have these four main committees. We have a Projects Committee that updates and produces new resources to enhance resident education and training. All of these resources are written and created by residents for residents. And participation in these projects allows residents to be both academically productive and also allows us to have a pool of great resources that are available to residents. The Education Committee oversees these surveys that we create that are national surveys for residents across the country. And they also assist the Thoracic Surgery Directors Association and then some of the major workforces in thoracic surgery education in the US. The membership committee is one that raises awareness of our organization and promotes resident recruitment to some of our specialty societies and then the field of cardiothoracic surgery in general. And then finally, we have a communications committee that allows us to communicate with residents and all the trainees across North America. So the structure consists of, the officers and then the committee members that are listed here for this year. We provide a lot of different resources, and Clauden will give you a little bit more detail of them later on. We also provide networking opportunities at some of the major meetings, annual meetings for the major societies of cardiothoracic surgery in the US. We also allow residents to have the opportunity to conduct research and publish as well. So we have residents submit proposals to conduct research, and we can have these national listservs so that these surveys are submitted to residents across the country, and these surveys are related to topics in resident education and training as well. And this has led to numerous publications over the last few years. And then we also have this new section in JTCVS, one of the major journals for the American Association for Thoracic Surgery, with young surgeons notes that we help create as well. We offer career guidance by providing resources and also helping to organize luncheons at the major annual meetings. And then we also help with awards as well. So we are the primary graders for two major awards for faculty, a Socrates Awards, which is targeting faculty more in their more senior years of teaching, and the Magoon Award, which targets faculty in their early years of teaching. So faculty have significantly contributed to resident education. And we also opportunities for fellowships as well. So we are fortunate to have good financial backing for some of the resources that we've been able to sell. And so with that money, we have been able to create traveling funds for residents, including a global surgery fellowship fund. And then we also collaborate with other societies as well, the American College of Cardiology, and then the American College of Surgeons as well. So that actually is all that I have here about our overview. Rodolfo, before we head into specifically our projects, anything, just overview of our organization in general that people have questions about?
So I think about the organization, we think that's okay. Yeah, we just would like to see how does these projects work and improve the residents.
Okay, I think Clauden has that slide deck, so I will stop my screen share, and we'll turn it over to Clauden.
All right.
All right, can everybody see my screen?
Yeah.
All right, so this is current and future projects of the TSRA. Just been reviewing some of the things that we've been able to put together. So we have a podcast that we've been able to make. We add about maybe 1 to 2 audio podcasts. It's usually an expert going over a specific topic. For instance, the 4 that is shown here are some of the more recent ones that have been added, and they go over coronary artery bypass graft conduits. We go over cardiac myxoma, and of recent, with all that's going on with COVID, we had some great expert talks revolving COVID, and then even in thoracic surgery, achalasia. So we get topics covering cardiac surgery, thoracic surgery, congenital, and it could be non-specific. It could be education, it could be based on how to be academically productive, access to practice and being a junior, attending. All these different advice comes together. We have a total of 106 tracks so far, and we usually average around 50,000 listens annually. This is the past couple of weeks, going into April. Some days we'll have 300 listens or more, so it's actually been pretty fun. This is kind of repeating the same thing that we just mentioned so far. So we typically add about 1 to 2 podcasts per month, and we'll keep that going over the next several years. And the methods in which you're able to find these contents are on SoundCloud, which is an app, and it has a website, or also on the Apple podcasting. We have it available there. We also have Thoracic Surgery Residents Association question bank. And this was actually taken today. We have so far 259 candidates who have subscribed, who are active users. This graph here is showing the number of exams that some people are taking in a day, some more than others. And we make it absolutely free and available for residents. This is kind of our goal. We want to make sure that the resources that we have can go to those who need them. So if you're not able to get other resources, we still want to make sure that our specialty will not suffer, and that we can essentially continue to attract the best and the brightest to stay academically on par. There's 4 disciplines with the TSRA multiple choice question bank: cardiac, thoracic, congenital, and trauma. And each of those have another additional 5 to 10 sub-subjects in which there are at least 10 questions in each of those subjects. And it totals nearly around 600 questions. I do serve currently as the manager, so to speak, for the TSRA multiple choice question bank. And if there's any concerns or errors, I'm able to actually change that question right then and there. It's one of the features in being able to manage it myself that I found very useful. I've made edits so far to 44 questions. The goal is that everybody is able to contribute. You know, as you do a question and you think things have changed, it's no longer accurate, you know, from what it was this year versus last year, or whenever there's an update to the guidelines and whatnot, we can stay on par. So it is essentially a live question bank. I added a new resource to the question bank that makes it such that you can actually randomize the questions. You can do as few or as many as you would like. So there's test mode, there's practice mode. You can do 5 questions. You can do 100 questions straight. You can do it over 1 or 2 topics, or you can do it over less. You know, and I think it's been pretty useful of recent. So that's the TSRA question bank, kind of in a nutshell. This is a picture. It's technically called the Fred software. So it's similar to when you have your standardized exam. Like, this is pretty much it. Is authentic in appearance. The questions present as they are there. You have your multiple choice. You can save. You can pause. You can do the test again. It essentially is the real feel of when you sit down for these examinations, this exam here. Of recent, I want to say that over the past year, we've been adding what's called a literature review. Our ultimate goal is to be able to have seminal work in our field available so that you can plan your journal club, so that you can say, hey, I wonder, you know, what is the citation, or what is the knowledge behind why it is that we do what we do? Coronary artery bypass, where's the IMA seminal article that speaks to it? This website, which is the TSRAlitreview.com website, kind of puts that together. So if you were to choose one of them in particular, say you choose congenital heart surgery, you'll see a couple of literature reviews that we put together so far regarding the field itself, and this is true for all 3 of the subspecialties. You'll see a breakdown of different topics. And I also want to say, similar to the question bank, it is alive. If you look at it today versus tomorrow versus next month, it will be different. We are continuing to add to the literature reviews as we come, and we are actually taking participants. So on the left-hand side, you can choose to submit a summary, and that summary will essentially be added. We have a method in which we go through the content and make sure that it is correct information, and we'll add that to our listing. We can continue to populate this. So as you guys join in this blog style seminal work review, you guys can be contributors, and your names will be populated on the links themselves as well. But what you'll also notice is that as we continue to create a lot of resources, we don't want to have a situation in which there's so many resources we can't keep control of it, or it's very difficult for individuals to navigate what to use and when. So on the left side, you'll see that there is a link to the TSRA question bank. So if you don't have that link, or you can't find the previous link, well, you can go to our literature review and you'll see that things are tied in together. You can click that link there, and that will help you get an account if you don't have one already, or you can just use that to log into the question bank directly. There's also links to our Facebook, where you can see the latest and greatest that we're putting up. We have newsletters that are coming out, and those newsletters are very useful. Alex will speak more on it as he currently manages to put that together. It's a great job that he's doing in that regard. But you'll have different dates of when different manuscripts are being accepted for publication and different opportunities specific to our field as residents. We also have a link to our Twitter specifically from the TSRA Lit Review website as well. So it's kind of putting everything together so you can do less work and not have to memorize any of these specific details. Some of our major publications or things that we've been able to put together is our textbook consortium. I would say so far we have put together a great deal of textbooks. And again, these topics have been created with resident input with attending partnership. So every chapter that is put in by a resident has their expert attending as a participant. And we use that in our publication. One of the more recent ones that we've completed is the TSRA decision algorithms, which right now, actually all of the 5 textbooks that we have right now that are on Amazon and Kindle are in the cardiothoracic surgery. They are bestsellers. Right now we have a number 7 and number 8, as you can see, which is the TSRA decision algorithms and our TSRA clinical scenarios. And by the way, we are updating our TSRA clinical scenarios. There will be a new version of that coming out next month. So we're very happy about the work that we've been able to do in that regard. Specifically speaking on the TSRA decision algorithms, just to quickly talk about that, it's essentially a 100-chapter compendium. It is a derivative of a safe method to do a certain procedure or the management of a certain pathology in all 3 of the subspecialties: cardiac, thoracic, and congenital. Each decision algorithm is the method in which an attending has put together with help of a resident of how they would manage it. And again, with all of the topics that we're putting together, there are more than one ways to skin a cat. Our goal is not to be inexhaustive. Our goal is to say, hey, if you're questioning how do I manage a certain pathology, well, then this textbook will help you have a safe method. And again, you can find all of these resources on Amazon. Our ultimate goal is to make these affordable. So notice you'll never see any of our resources, a cost of $200 or more. We price it in such a way that residents can afford it. We also create some resources that are absolutely free, and they're based on our TSRA net website, .org. We have the TSRA Pocket Mentor, and that resource serves as a guide. It's written by residents, faculty, program directors. It essentially covers an array of topics that are essentially not found in textbook. How do I find time to read? How do I hone my technical skills? What is the method in which I can approach and find a mentor? How about conducting research? And some of these things are useful for even international residents, where you can kind of use some of these details to speak to the faculty that are here in the States or otherwise in your local area, and try to use that to expound on your early career success. We have the TSRA Intern Survival Guide, and that's also a valuable resource. It is helpful, and it helps to remain filling the gaps of knowledge and skills. And for our junior individuals of the field, how to manage hypertension, hypotension, chest pain, low urine output, the different common bedside procedures. This puts a survival guide in place so that you can have quick answers to some of those things. I'm going back on some of the textbooks that we've created. The TSRA Review of Cardiothoracic Surgery, we're very proud of. It essentially is, again, of all of our 3 subspecialties, cardiac, thoracic, and congenital, a summary of the critical information. And it's not exhaustive. It's not built to be a 300-page review of a topic, but essentially gives you a review. So as you're reading the exhaustive textbooks, the cones, principles of surgery. I'm going through, the shields of thoracic surgery, the 2-volume edition textbooks. You can then look at these TSRA reviews, and it can keep in your mind some of the broad review topics, so you can organize it in your head, and it can essentially be able to come out as you try to review the critical information that is out there. We also have a TSRA primer, which I think is also similarly useful for the junior members of cardiothoracic surgery residents. It is different because it's interactive. So on iTunes, it's available now. You can get the TSRA primer, and each chapter has essentially videos that you can look at. There are pictures as to like bypass setup, getting on pump safely. It's tailored to the young stage of learning cardiothoracic surgery. There's the clinical scenarios, which I mentioned we are having a 3rd edition that will be coming out next month. But it itself goes over the differentials, history, physical tests, the index scenarios, the treatment management, the operative steps. It's the closest thing to going through a scenario in your head so that you can have the pearls and the pitfalls of different pathologies ready to go. They go through alternative scenarios and potential opportunities for you to intervene and salvage a certain procedure that's not going a certain way, to begin to resuscitate, to know when there is a concern. You're doing a procedure and patient has VFib. You're not in the chest yet. What are some of the things you should be thinking about? Setting up bypass and doing a procedure where you now want to get cardioplegia, but you have severe aortic regurgitation. What are you going to be your plan, moving forward? This helps you to bring those things to light, where you review the common high yield principles. Then there's the TSRA operative dictations in cardiothoracic surgery, which goes over the procedures so that you are able to talk and expound in regards to the descriptions of how you conduct an operation from start to finish. And that's also pretty exhaustive of all 3 specialties: cardiac, thoracic, and congenital. And again, the TSRA clinical scenarios, stay tuned. That's coming out next month, June 2020. But we also are looking at having a video resources that will be coming soon as well. So you stay tuned, and those websites that we shown are essentially the methods in which you can find all of our resources. And that's pretty much it. I thank you for your time and for listening to some of the projects that we are doing.
Yeah, it's amazing. We already saw some of the projects like the mentorship book, the TSRA clinical vignettes, and also the podcast is really good. We have some singing, and we listen sometimes this podcast. We find this very useful here too. So just a question: do you guys have logbooks in the US? Logbook surgery, where you put your what you did in your surgery in your time room?
Yeah, we have a, so it's online and it's through the ACGME that we have to log our cases. And it's all online, and basically you pick what case it was, and then you indicate if you were the surgeon or the assistant. And so for cardiothoracic, there are some of those component cases like Dr. Lowe was talking about, like sternotomy, thoracotomy. So for the junior level residents, there's a certain number of those that they need to do, and they would log it that way as that component of the case. And then beyond that, the ones that count are when you're logged as a surgeon, and that's a often debated concept as to what qualifies as being as the surgeon. And for the numbers that Dr. Lowe is showing, usually that doesn't necessarily mean skin to skin. The way that some people think of it is if you do more than 50% of the case, then it would be logged as a surgeon. But I think some of that's going to be variable by institution as well. And so that's the official logging system. I can say I have, actually up here, I have my own book where I have every case that I did, and then I have like a patient sticker in there and write down the details and write little notes for myself. But the actual way that it's logged formally is online.
Yeah, we have a question close to this one, and I would like to ask is every resident in the US, the necessary surgery, the logbook, the skin to skin, AVR and CABG is 150 surgery approximately. Is that right or not? As I saw in the showing low presentation.
Yeah, I think it's a little different if you're on the cardiac or the general thoracic track. And I don't know it by heart, but it is what Dr. Lowe showed. I think it's 80 CABGs and then 50 valves are the two biggest categories. And then there are a number of smaller categories. And you still have to have a minimum number. If you're a cardiac surgeon trainee, you still have to have a minimum number of general thoracic cases. It's just less than a general thoracic trainee has to have. Because our board system, to be boarded in cardiothoracic surgery, you're technically boarded in both cardiac and general thoracic. And so it's never all of one in terms of a board requirement. A lot of people practice all of one or the other, but some people also practice both.
Yeah, as a cardiac surgeon, at the end of the residence, do you have the all necessary surgeries skin to skin, or do you need to take more 1 to 2 years to get those surgeries to complete your ACGME certification process?
Right. I think that goes also to what Dr. Lowe was saying, where they're moving towards a competency-based model. And so it's kind of a combination of everything. It's a combination of numbers, but those aren't so strict that it's impossible to graduate without them. That being said, most, if not all, graduates have met the minimum case requirements, and that's why they're minimums. But then there's also different components of competency, and then there's time. I think compared to some other models in other parts of the world, or even in the US in the past, I think that there's less variation in terms of time. So I think that most people finish in the time that they're designed to finish in, which for us is 6 clinical years. And then through the traditional pathway is general surgery, and then 2 to 3 more clinical years. But there are, of course, exceptions to that. And that's sort of on a program by program basis in conjunction with our board of cardiothoracic surgery. So they would, decide if someone's maybe not ready, or if some life event happened and they needed more time or whatnot.
Yeah, thank you. The second question is about the key bank from where Dr. Clauden said to us is already 600 questions. And how many questions is the process to get the ACGME certification in thoracic surgery? During the test, how long is the test, and how many questions there are in the test? Yeah. You guys know?
I don't know off the top of my head. I don't think.
Do
you know?
I do not think I know at all. In fact, I probably have to ask some of my graduating chiefs. We wouldn't have knowledge of that exam typically until we're ready to take it, which is somewhere after our 6-year training program. Having said that, I'm sure that information's out there. I'd like to say it's going to be plus or minus 200-300 questions. We do in-training exams every year where it's about that much, and it just takes 200-300 questions to kind of stratify residents and test takers so that you can have the percentiles. It doesn't take 500 or 600 questions to do that. So I'd like to say it's somewhere probably half the number of question bank questions that we have there. But what I will definitely say about the question bank is the ultimate goal is for it to be helpful. I wouldn't say and or recommend that is going to be a resource that you use so that you can sit for your boards. It would not be a recommendation of ours, and it shouldn't be. In the end, Sitting down for your board should be a conglomerate of things. Should be your training, should be the textbooks, the resources that you're using, should be conversations with the actual board company that it's coming from. The question bank complete resource tool use is for you to be able to have something that you can bounce ideas off of, that you can learn, that the resources that you are using, information can stick. I don't know if I would say that that's something that we're using right now to sit down for our standardized boards.
We don't have it right now in Brazil.
Yeah,
you can.
I was just going to say, I sent a text message while we were talking about for boards, and one of our graduates said that he doesn't remember the number of questions, but he thinks it was about 6 hours. So,
okay,
which is longer than our in-training exam.
Wow.
And that's the written boards. So there are two parts for our boards. There's oral boards and there's written boards. And the oral one is you're in a room basically talking through scenarios with board examiners who I think by definition, they can't know you well going into that. So they have to be people that aren't very familiar with you. But there's two separate tests that you have to take.
Do you guys have the access to this test or not? The questions of the test or not? No, after the test. No, just to correlate the question in order to produce your questions in the key bank. Yeah.
No.
They're very protective of it too, so.
No, it's look like the UWord for USMLE. The guys get those questions and bring back to UWord question, like the USMLE or REX and UWord for the USMLE.
Oh,
we have not done that. That's not something that we have done. And typically speaking, the individuals who are producing resources are all not board certified. The attendings are, but we as residents have not taken the exam, and we've come up with the resources with our attendings. So no.
All right.
No, that being said, I think something that's nice about it's one of the perks, I think, of being the one of the smallest specialties, and I think that there's a lot fewer topics compared to general surgery, for example. So, there are really basic disease processes that we hit on in all of our resources, and that's typically what you're going to see on boards. And that's not me saying that because I haven't taken boards, but there's only so many topics that can be tested. And so what we try to do is hit on all the topics that are necessary to practice as a cardiothoracic surgeon.
All right. Also, the approval rate is really good in the US for ACGME, for cardiothoracic and thoracic boards.
You mean the pass rate of?
Yeah, the approval, the pass rate,
Yeah, I don't know off the top of my head. I know that it's higher for written boards than oral. I believe at one time it was about 65% at the first attempt for oral, and I don't know if that is still true. You can take it multiple times, is another aspect of that. But I don't know if Clauden or Shasha knows better numbers.
I don't know the most recent numbers. Yeah. At one point, someone had said, and I don't know if this was just lore, that it was like 50% pass rate, but that probably not in more recent years. So probably just to scare us, I think. So.
All right. Let me find the other questions. Yeah, what about publications in the US? The research publications and curriculum, is that really important or not too much?
I think it totally depends on what you want to do with your career. And so if you want to be in an academic or a university setting where you're part of a university, you're part of a medical school, then yes, I think it is important, and it's part of what's expected of you for career advancement. And if you're not interested in that and you want to be in a more of a community setting, then I think it's less important. And I think that's a continuum around our country. So I think that there are practices that are also in between. And as a resident, you might not know. And so that might be one way that you can try and see if it's something that you want to be part of your career down the line or not. And I know Xiao showed the different structures are, a lot of the integrated programs, some of them do not have research that's required. Some of them have optional research, and some of them have strongly encouraged or required research. And initially ours was not required, and I chose to because I wanted to, these 2 years in the middle, because it was something that I wanted to make part of my career, still do. But currently all of our residents have what we call here, it's called academic development time, but it's basically research time. It's that 2 years in the middle. And that can be a number of different things. It can be research the whole time. It can be in a lab, it can be clinical research, and it can also be a critical care fellowship. So a couple of my co-residents have done our 1 year critical care fellowship during that 2 year period, and then did something else for the other year. So it can take on a bunch of different iterations, which in general, I think is one of the strengths of the integrated program, is that there's some room for molding things according to your interests and goals.
All right, thank you. The next question is, what is the job market in the US right now for young cardiothoracic surgeons?
Very good, I think. I don't have the latest numbers, but anecdotally from talking to residents who are graduating, there is no shortage of available jobs. I think it depends a little bit on what kind of job you're searching for. Obviously, academic jobs, if you're searching for one particular part of the country, you'll have some more limited options, but people have not had trouble finding a job in general after graduating.
I think the only thing I'd add, the one exception is for congenital cardiac surgery. So those are, there are a lot fewer jobs, obviously, which is true all across the world. It's kind of a whole different job market and different proposition. One thing that we don't know yet, but will be interesting to see, is if the job market changes because of COVID.
Yeah.
So it's kind of too early to tell, I think.
Yeah. Also about the future of cardiothoracic surgery as a structural heart disease, as we can see the mitral valve, transcatheter, TAVR, TVAR. And what do you think about this relation with interventional cardiology right now in the US? Is that good with cardiothoracic and interventional cardiologists in doing the case, or just interventional cardiologists are doing the case in some places? What is the?
I think like you were describing, I think it's really highly variable. And I think a lot of us in a training setting, we're in large academic centers, and speaking from Michigan, all of our cardiologists, our cardiac surgeons, our vascular surgeons, our interventional radiologists, everybody works really well together. And there's the concept of a heart team in doing these procedures. That being said, I also have to acknowledge that also biases us somewhat, because if you're in a large academic center and that's what that it's not necessarily true everywhere else in the country. And it's important to remember the majority of people do not practice in a large academic center. And so, like you alluded to, I think it'll be interesting to see. I think that for TAVR, it's pretty, the concept of a heart team is pretty well ingrained in the US. I know it's very different other places in the world. For the mitral valve, there's not the same requirement that there's those two operators together. And so I think that's sort of yet to be seen. And that's just my opinion, but I think it'll, the surgeons that will be involved in that will be their specialty. They'll be a mitral specialist where they make a specific effort to do interventional mitral procedures. But it's sort of yet to be seen how that's integrated into the overall training program in the US.
Do you have the information for the Emory University is one of the best in structural heart disease, as
yeah.
we know, yeah. What are your thoughts about this question?
Yeah, so we have, in our program for the I6s, in our last year of training, we have 3 months that you can spend on elective time. So with those 3 months, because of the breadth of resources in structural that we have here at Emory, as you alluded to, a lot of the residents end up doing 3 months of structural heart, like a mini fellowship within their training. And it's very well incorporated here. They do a lot of cases, and they're basically the structural heart fellows. So they see those patients, they round on those patients, they're in there doing all of the cases. So, that primarily is centered at one of the hospitals in the Emory system. And, I haven't done that rotation myself, but I've seen how the clinic and how the rotation there is structured, and it's very hands-on for that particular resident for that opportunity. And the interventional cardiology team, like Alex was saying, it's a heart team approach at Emory as well. So every patient that could be a candidate for TAVR gets evaluated in clinic with the cardiothoracic surgeons as well as the interventional cardiologists, and they make a joint decision and put them on the schedule so that both of them are available to do that case.
I guess I will echo the same thing that Zhao was saying. At our center, we do it kind of differently. We don't have a separate rotation for TAVR procedures. Right now, our current chief cardiac surgeon, he has like a TAVR day. So like Tuesdays and Wednesdays, he and our other senior cardiac surgeon will do TAVRs for that day. So that's 3 or 4 cases. And because we can choose to have an apprenticeship model, I can be with him and I'll do the cases for the TAVR, and I'm right next to the interventional cardiology fellow, who was a PGY7, and at some point I was a PGY2 in that room, and I'm doing the procedure, such that I've now seen it enough times where I'm doing the TAVR cases skin to skin. That may not be true for the more complex open surgery cases for cardiac surgery, but definitely for TAVR, I've realized that there is a method in which surgeons can learn those skills and acquire those skills very, very well, faster than the average cardiology trained individual, So I do think that it is important for us to learn those skills, because it is going to be part of our future, and we're going to be able to do as much as our training dictates and as much as we continue to push for that exposure, for that experience. Any other final questions?
Yeah, just the last one, and the most I think difficult one is what are your thoughts about the future of cardiothoracic surgery? Do you think will be better or worse than that is why right now? What are your thoughts about this? What do you guys think about the future?
We're all probably a little biased because we're in it, so it benefits us to all say we're all very positive about it. And I think we see each other at the conferences. We're all pretty involved as residents, I think, within the specialty itself, and everything that I'm kind of speaking on behalf of Alex and Clauden here, so feel free to give your own thoughts. But I think everything that we've seen in terms of the emerging technology, minimally invasive, as you pointed out, endovascular therapies, robotic, everything is painting a very bright future for the specialty, and we're just evolving training to be able to catch up with all of that and be able to be ahead of it. And I think there was a point in cardiothoracic surgery, probably around the early 2000s, where people were saying, the specialty isn't going to last. There's too many other things that are, they painted a very bleak picture of it, and that has drastically changed in the last decade or two. So I'm very hopeful for things, and optimistic about everything that's going to be happening and changing in the specialty.
I agree. I think the future is very bright and exciting too. I think there's a lot of developments that are happening that is, really for trainees right now. I think we're in a perfect position because there's still a good amount of open cardiac surgery that's done, and there always will be, because there will be failed procedures that are transcatheter. There will be valves that have to be replaced. There will still be coronaries that need to be done. So there's always going to be some amount of open cardiac surgery. And I think what's great about being a trainee now is that is still routine enough that we are learning those skills, and then we can also learn the new technologies that are evolving. And so I think focusing on sort of building that toolkit of skills to manage cardiac disease should be everyone's goal. I think it's a good time to be in the field.
All right. Do you have any thoughts, Dr. Clauden?
Well, I agree with what my colleagues are saying. I do think that there is a great future here in this specialty. We're learning a lot. It's a steep learning curve, but definitely well worth career. Not many people can do what we do. Ultimately, you need to have a transplant. The chest has to be open. There is no other specialty that can do that, you know. So I think that there's going to be a lot that's happening here from a global perspective in this field. And I think, if anything, COVID has actually made the global perspective even smaller, because now we're able to communicate in this forum here where we can catch each other up to the opportunities and educational opportunities to advance our specialties. Okay.
All right.
We'll be able to email you guys the links that we mentioned from the websites and our contact information for TSRA. Okay.
Thank you very much. It's
Absolutely.
wonderful.
Thank you so much for the
content to share with everyone. It's a pleasure to have this content to see and
thanks for having us on.
Yeah, we appreciate the opportunity to have you reach out to us, Rodolfo. We have focused so much on North America, but I think part of our focus for the future as well as an organization is to try to collaborate more with residents across the world as well. So if we can focus on resources that benefit all of us, I think we have, that is another optimistic aspect of this specialty, is that it's no longer just regional. We can have a worldwide collaborations. So
yeah,
good to see all.
Yeah, we do think the same. Yeah. Right now we need to share with the ideas and thoughts with everyone. And it's a pleasure to have you guys here. Thank you very much. And that's an amazing ideas that everyone, Dr. Clauden, shared with us, that we need to try to develop here in Brazil too. We need to have a logbook. We do need to have key banks and other projects like you guys are doing really well in the US. Thank you very much for the presentation. And
thank you.
Have a good night, everyone. Thank you very much.
All right. Thanks.
See you. Bye-bye.
Bye.